So I'm really thrilled today to have wrangled Dr. Lauren Harshman for an interview. Dr. Harshman is an assistant professor at the Dana-Farber Cancer Institute, focusing on kidney cancer. And I have to tell you, if I had to put my bets on the one person that's going to cure kidney cancer within the next 30 years, I'm going to put the onus on her. I think she could do it. So Lauren, thank you so much for joining me today.
Thank you, Monty. It's a pleasure to be here.
First, we've had a lot of talks regarding immune-based therapies, and in renal cell carcinoma, a lot of our discussions have focused on PD1. So what is PD1?
Yes, that's a great question. You know, I think we've seen in kidney cancer sort of this resurgence of interest in immunotherapy, really trying to retrain or re-educate our bodies to recognize the tumor and to kill it. And we have certain immune cells, like T-cells, that actually can recognize cancer and eliminate it. However, tumors have evolved to sort of express certain proteins on their cell surface that can actually evade the T-cells. And so one of those proteins is PDL1, the ligand or a protein for the receptor on the T-cell called PD1. And so that's sort of the simplified version. And so when the protein on the tumor cell surface binds to the receptor on the T-cell, it basically turns off the T-cell, and the T-cell no longer recognizes that tumor as bad, and it sort of allows the tumor to grow and evade the host's immune system.
It's a great response to the question, and I wanted to follow that up with something that oftentimes is the first conversation we have when we're meeting a new patient with kidney cancer. We discuss some of the older therapies like interleukin-2 and interferon. How do you contrast those older generations of immune therapy to PD1 inhibition and some of the new strategies that we're toying with?
Yeah, so how I've been thinking about it is, you know, we're in the era of the targeted therapies for renal cell, and these are different. They're not necessarily focused on the immune system, but they are targeted to certain mutations that allow and actually drive the tumor cell's growth. Our old immunotherapies, interferon and high-dose IL-2, they did have a role. They were effective in a select few, this durable complete responses, albeit in less than 10% of patients, this sort of equating to a cure even when patients had metastatic disease. But they're very toxic, and we really couldn't pinpoint who was the best patient to give it to. So I kind of feel like I sort of put them in the realm of sort of non-specific immunotherapies. And now we're talking about this more specific or almost targeted immunotherapy targeted to the T-cell. So this trying to rev up the patient's T-cells by turning off sort of this negative signal from the tumor.